Hi, I'm Kevin Kalinsky. I'm the Division Director of Medical Oncology at Winship Cancer Institute in Atlanta, Georgia. I am very pleased and happy to be joined by my colleague, Dr. Sara Hurvitz, who's the Senior Vice President of the Clinical Research Division at Fred Hutchinson Cancer Center and Head of the Division of Hematology and Oncology at the University of Washington Department of Medicine. Dr. Hurvitz, good to see you.
Great to see you, Kevin.
So we've seen some exciting data that we have been awaiting. In particular, I would say the most anticipated data was from the DB06, the Destiny Breast 06 study. Maybe we can just talk through that study. I'm curious about your perception of that study and how we will best utilize that study when we're taking care of our patients with hormone receptor positive disease.
Yeah, it was a really interesting clinical trial looking at trastuzumab deruxtecan, TDXD, in patients with hormone receptor positive metastatic breast cancer that was HER2 low or ultra low expressing. So they allowed patients on who had HER2 IHC 0 as long as there was up to 10% of faint staining for HER2. Patients were allowed on if they had exhausted endocrine therapy options. So they had to have had endocrine therapy, most CDK4/6 inhibitors, but no chemo yet. So this is like a frontline chemo, but not a frontline study. Comparing TDXD to treatment of physician's choice, which was essentially capecitabine or taxane. Capecitabine was had by about 60% of patients in the TPC arm. And they reported a very significant improvement in progression-free survival, very impressive hazard ratio, about a 5-month delta, if I'm remembering correctly, 8 to 13 months with TDXD. The survival data were immature, of course, but this now places TDXD not after chemo, but as in front of chemo. I think a lot of things are important to consider, and first of all, being that many of our community oncologists are incredibly busy and are treating multiple tumor types, you can hear top-line results like this and misinterpret and think we should be replacing TDXD in the frontline setting, and skipping over endocrine therapy and CDK4/6 inhibitors. And that's not the message from this trial. We should be exhausting endocrine therapy options first. But I do think these data are very important and especially if they end up showing survival benefits, place TDXD earlier in front of chemotherapy. But I don't know. What do you think?
Yeah.
I mean, capecitabine is so well tolerated and it's oral.
Definitely. I mean, I think the first point that you made, I actually think is a critical point, is just that these are patients with hormone receptor positive disease. We want patients, this is a marathon, right? We want patients to be able to utilize endocrine-based treatments for as long as they can with targeted therapy, ideally, before we need to utilize something where they have to spend more time with us at the infusion center, et cetera. And so it's a really important point. And when I was a fellow 1,000 years ago, we used to give our patients chemotherapy in that front line. We've really moved away from that, where we give doublet endocrine therapy and CDK4/6 inhibition. That should remain the case. And so for those patients, when they become endocrine resistant, then it's a question of whether we should be using TDXD versus something like capecitabine. And for me, my clinical interpretation of the data is if I have a patient who has a slow-growing tumor, maybe remains bone-only, I'm not concerned about their pace of disease, capecitabine is still a reasonable option. But if I have somebody who I'm concerned, I feel like I need to get a response, like those were some additional notable data. The response rate was over 60% in that population. Right. It's an active drug, TDXD. Then I would consider giving TDXD. And the other thing is there were no additional safety signals beyond what we know, because we're now very familiar with what we should be checking and making sure that we're looking for interstitial pneumonitis, given that is a potential toxicity.
Yeah, the one thing that was a little bit different, I believe, from the written abstract than what was presented was there are 5 deaths from ILD, underscoring the importance of us stopping therapy, watching, with even grade 1, utilizing steroids aggressively to mitigate that. The other point that somebody made that I thought was salient is that only 20% of the patients who were on the treatment of physician's choice went on and received TDXD at progression. So we don't know if patients, having TDXD at first line chemo or at second line chemo makes a difference. That's something I think we're going to have to wait and see as the survival data mature.
For sure, for sure. So two things. One, for the survival data, there were some patients, I think it was about like 20% or so who crossed over, and we'll see
Yes.
like how this looks, and the point's
Yes.
very well taken in terms of what patients receive subsequent lines of treatment.
Right.
And then that HER2 ultra low population, right? So I believe the general, for the patients who were HER2 low was maybe like 700 or so patients, like 150 or so
Yes.
who were ultra low. Question is, what do we do with those patients? Because during that session, I was texting my pathologist being like, well, how are we going to report this? Because we don't report it in a spectrum like that. It's either 0, 1, 2, 3. And it raises the question of, well, should we be thinking about utilizing this just in all patients, regardless of HER2 score? Though that's not what the indication is right now. It just raises the question. But then just working with our pathologist of how we're going to be determining that someone actually has HER2 ultra low disease.
Absolutely. Quantification of HER2 is going to be so important. And I know there are a number of groups working on new assays because IHC was never meant to be a quantitative assay. And I agree with you. It's going to be very difficult for us if the FDA expands the label for this drug, including ultra low. Yeah. We don't have a companion diagnostic, so it's going to be very interesting.
For sure, for sure. So I'm going to switch topics because we were talking about endocrine sensitive disease. So we also, the other day, right, the other day, we saw the results of Post-Monarch. And this was a study where we'd seen some phase 2 trials that demonstrated some inconsistent findings, though the phase 2 data that we had was suggesting maybe there was a benefit of switching. And in this particular study, patients had endocrine therapy with an aromatase inhibitor and a CDK4/6 inhibitor. It could have been any of them. And then they were switched to Faslodex plus placebo fulvestrant plus placebo versus fulvestrant plus abemaciclib. Randomized phase 3 trial. And it was a true second-line study. Patients did not have chemotherapy in the advanced setting. So I'm curious your interpretation of those data.
Well, it's the only phase 3 trial to address whether continuing a CDK4/6 inhibitor after progression on one is beneficial. So I think it's very important data just based on the fact that that trial was done to confirm the findings of MAINTAIN, which were very compelling, interesting phase 2 data that you presented. And I thought, it met its primary endpoint. It did have a good hazard ratio showing benefit by continuing the CDK4/6 inhibitor. It's really interesting, though, because we're treating it as though abemaciclib is just a CDK4/6 inhibitor, and it's a different drug. It's far more potent. It is far less selective. It's hitting other kinases that may be implicated in the development of resistance to CDK4/6 inhibitors. And as you mentioned, like 60% of the patients enrolled in that trial had received Palbo first, then went to Abema. And that, on the forest plot, seems to be where most the benefit is coming from. The 30% or so of patients who went from Ribo to Abema. What do you think of those results?
Yeah. I mean, I think that this was the largest population that we have of post-Ribo so far, right? And we'll see other data sets that should read out hopefully in the next year or so that's looking at this post-Ribo and how patients with endocrine therapy with or without a CDK4/6 inhibitor do, like the upcoming EMBER-3 trial. And so, that hazard ratio, as you mentioned, was 1. That confidence interval was wide. There were less than 100 events, and the interaction p-value was not statistically significant. It is interesting. We will see if that signal continues, because to me, there is this question. As you mentioned, I don't think that all the CDK4/6 inhibitors are the same. And so, for me, when I think about those data that were presented for Post-Monarch, the patients that I would think about continuing CDK4/6 inhibitor, in this case abemaciclib, would be those that did not have visceral metastasis. And then also those, though we did see if you had liver metastasis, that the hazard ratio was about the same. And those who were on their CDK4/6 inhibitor for greater than or equal to 12 months. The other thing is about 30% did not have an ESR1 mutation or a PI3K pathway signaling alteration. And so for those patients where we don't have specific targeted therapies, this offers one to those potential patients. Would you think about utilization any differently?
No, I completely agree with you. And I think what we will be doing in that setting is testing ctDNA at the time to figure out, is there a more targeted, selective way to go with our treatment? If there's a PI3 kinase mutation or an AKT mutation, we're probably going to choose a different regimen, but I completely agree with you.
Yeah. So along that topic, the other thing that we saw during the session was just updates on some of the studies that we've seen previously, including the Inavo 120 study, where we saw recently that Inavolisib got breakthrough status. We anticipate that this will be something that we have in our clinic. Just talk me through the design of that study and where you think the utilization of Inavolisib will be.
Yeah, this was first presented at San Antonio sort of as a late breaker, like Friday session before we all got on the plane. There was like this last minute added session looking at this phase 3 clinical trial of Inavolisib combined with fulvestrant and palbociclib compared to fulvestrant palbociclib. Inavolisib is a PI3 kinase inhibitor, and this study actually demonstrated a very compelling progression-free survival benefit, a strong trend toward overall survival, and what was most compelling, I think, was the safety. Didn't appear to have the level of grade 3 diarrhea or hypoglycemia that we all contend with by hitting the PI3 kinase pathway. So very impressive data, and here at ASCO they've presented some updated adverse events as well as PFS2. The efficacy data continues to look compelling, and what is really surprising is the relative lack of grade 3 events when you're looking at rash, diarrhea, and hyperglycemia. But one thing to note is these were highly, highly selected patients. The HbA1c levels at entry were very restrictive. I believe it was the HbA1c of 6 or 6.5 to get on the study. Other studies have used 8. So these are data that I think are going to have to be confirmed by real world evidence to see really how well it's tolerated when we get it out into a general patient population who may not have been fit for this clinical trial.
Yeah, I agree. So the population, as you mentioned, was this endocrine resistant population, right? So these patients who, had tumor progression within 12 months of their endocrine therapy. So it's a very select population. Yes. And, the doublet, they did not well at all, right?
Yes.
So that's why these data, I think, were so compelling for this population. And so when you were to think about when you would be checking circulating tumor DNA for you, you think that it would be just those patients that you would be checking circulating tumor DNA earlier, or is your practice now, even at the time of metastatic diagnosis, doing next generation sequencing?
Yeah, I think if this regimen is approved, we're going to be compelled to test and do next-gen sequencing on our patients at the time of diagnosis of metastatic disease, especially if their disease is behaving in a more aggressive manner, as you said. Do you agree?
I do.
Okay.
I do.
Yeah.
This is great. Anything else that was on your radar?
No, I think this was an exciting conference, a lot of data out, but I think those 3 abstracts were pretty much top.
Yeah, I agree. Well, it's been great chatting with you, as always, and enjoy the rest of your meeting.
And you too.
Thank you for joining me. This is Kevin Kalinsky speaking from the 2024 ASCO Annual Meeting in Chicago.